You're watching CTOM TV. Knowledge is power.
But you go ahead and let Alex know a little bit about your case and what you'd like to know.
Yeah, sure. Well, I was discovered that I had a polyp, a cancerous polyp, on my first colonoscopy, just a routine colonoscopy in 2017, and ended up having a resection just to take out a small bit of bowel, just to be absolutely certain, I guess, that it wouldn't spread. It was a tiny little polyp. And unfortunately, in 2018, a tumor recurred at the surgery site. And so in 2019, I underwent adjuvant chemo and radiation prior to surgery, and had another bowel resection. And that didn't go quite as well. I ended up with a colostomy that didn't work well, and was in hospital for a couple months. And I now have what was supposed to be, I guess, a temporary ileostomy. And you think, well, at least things got better after that. And unfortunately, they didn't. I was just getting back to work when COVID hit in the spring of 2020. And so a follow-up CT was delayed. I'd last had a CT, I guess, in January 2020 because I had a pelvic abscess. I had an infection, and it was one of the reasons I was in hospital so long. So I'm just getting back to normal. I'm hoping to get something. I got a CT in July of 2020, a year ago. And unfortunately, it showed that the cancer metastasized to my liver and lungs. So a bit of a shock, and took me on a completely different direction. I've been hoping to discuss, reversing the one or both of the stomas. And since then, I spent the month of September last year in Germany at an integrative clinic doing some mental mind-body work and other some therapies, including experimental one called insulin potentiation therapy, where they use low dose standard chemotherapy, 5FU, for example, and believe that the effect may be enhanced by promoting basically the sugar uptake, almost like the PT scan. It's theoretical. It's not strongly based on evidence, but there's some suggestion that maybe that would be more effective than dosing your body with chemo, which I wasn't intent on. And then while I was there in Germany, I was alerted to the possibility of having the liver tumor, which was then about 5 centimeters, pretty big, operated on by way of a microwave ablation. And that's something I guess I want to ask about, because it seems to me that that's a non-invasive or minimally invasive way of dealing with something. In my case, I'm not a candidate for surgery. At least that's what I understood from the surgeon when he called with the news about the metastases. And I can't say how effective that was, because the next CT scan I had about a year ago showed the tumor slightly larger, but one of the effects of an ablation is the tumor flare. In other words, much like you described with the immune therapy response, you'll get a reaction in the tumor, and that sometimes or often will show as the tumor being slightly larger. And I've never had a PET scan. I've just had CT scan images, and even the radiologists, I think, covering their butt, is saying on that October a year ago CT scan, it would be impossible to be more determinative about what's going on there. It could be necrotic tissue or whatever, without something like an MRI, which I'm not sure how much more helpful that would be. My question, I guess one of my questions, is about the utility of a PET scan to know if I'm looking at something else elsewhere in my body. And I was concerned, although they have a standard way of dealing with things, but I was concerned about the rising CEA levels. And that's what happened when I had my CEA level. I asked my family doctor to run that in November. And I was doing a bunch of other things that I consider helpful, if not, every little bit counts. Mind body work, meditation, stress reduction, diet, exercise, paying attention to those things, at least getting lots of sleep, doing things that I thought would put me in better shape if I had to do chemo. I wasn't keen on doing chemotherapy, but I did have genetic testing done. Well, they had done testing on the tumor while I was in Germany. So when I came back in October last year, the oncologist said, "Look, here's what we're recommending," and it was basically FOLFIRI with panitumumab. Right. So that's when I got the CA results, and they were off the charts again. Normal levels 5 or whatever. I knew it would be high, but it was it had been in below hundreds in Germany, and it was double that in November. So going from nothing in January of 2020 to a 4 centimeter tumor in your liver and spots in my lungs in July, the indication is I've got some kind of aggressive tumor. Thankfully, when I heard about the tumor testing, they said I'm negative KRAS, negative NRAS, negative BRAF. So those things are available. So I started right away on the panitumumab and the other three. And that went okay until March, when I had a heart attack that was caused by the 5FU. So that was unfortunate. Yeah, the good news is I got a free angiogram and I have no coronary artery disease. But they had to stop the 5FU, obviously. I was glad that they didn't try to wingle it in the backyard or back door and say, well, we'll try it with some calcium channel blockers or beta blockers or something. They did put me on those because they don't exactly know the mechanism of action of why the heart attack's caused. They just know that it happens. Yeah. So basically, and after that, I had a bowel obstruction in May, which is caused by anti-motility drugs, because one of the reactions to the irinotecan is diarrhea. Right. And even with an ileostomy, that's not great. You can get dehydrated. So I went off chemo for the summer as planned. I took a planned chemo break, and the tumor was actually smaller. It was below 3 centimeters, more like 2 centimeters. So I was thinking things are going well,
In your liver?
In the liver, yeah. And I was really quite pleased with that,
It went from 5 down to 3?
Yeah, it was reacting well. And this is, by this time, following March, I didn't have any 5FU or leucovorin after March because of the so I was on panitumumab and the irinotecan alone.
Right.
And I'd been thinking, wow, this positive response was due to the 5FU, the combination of all three, whatever it was, all four of them. But it does seem there was some ongoing effect of just the irinotecan and the panitumumab.
Totally, yeah.
So basically, what happened was I went back and had a recent one. Sorry, I had a recent one, and unfortunately, the tumor was back over 5 centimeters, and the lung spots are doubled in size. Not unusual, I guess, with going off chemo, but I guess I'm looking at some of these other things and going, okay, I take a baby aspirin every day because of that was the cardio. That has nothing to do with the, and I take, statins. I'm on navastatins every day. So it's like, okay, little things like that. I'm doing those other things that we talked about, but I had really hoped to get the tumor size down, and I would consider doing another ablation or something, just because of the minimally invasive nature of it. But if it's just going to grow back, it may be the same thing. Same reason the surgeon doesn't want to do surgery. It may, so I guess I'm on a one-way road here. I'd like to make it as long a road as possible, I guess. I'm in a pretty good mental space, but it's not where I want it to be. I kind of hope to be, you don't get rid of metastatic tumors. Even the doctor in Germany is like, look, standard care, even precision oncology doesn't normally, you live with cancer for the rest of your life. You don't normally eliminate large solid tumors in your organs. That's just not where we are medically.
So you've given me a ton of information. I apologize. I don't have a photographic memory. But
sorry.
Just to double back, I've got a bunch of questions. So after your initial diagnosis, and when you first had your polyp removed, did they not give you a full body scan?
Yeah, I had nothing after that. And the other thing, I mean, it's all woulda, coulda, shoulda. And I'm not, I should mention, I'm actually, until I've been off of medical leave, I'm a lawyer. So I think the surgeon who did the resection was quite freaked out because he realized that when the tumor recurred, the anastomosis, that I'd never been sent for a referral for chemo. And the initial biopsy results did show the margins weren't clear, less than 0.1 centimeter, like millimeters away. There was basically what they call a tumor deposit. So it was likely that it spread right from there. And who knows, adjuvant chemo is about 50-50. So who knows if that would have prevented it from spreading, but it would have been nice to at least get.
You definitely should have had a PET after that, because then they could have at least dealt with it and treated it, and realized that you had this thing growing that was probably missed. So there's a bunch of different liver targeted therapies. Sloan Kettering has a great one for larger tumors. And it's just where they basically put a tap into your liver, and they filter sometimes heated chemo or a different combination of chemo drugs at a very high concentration. It's very expensive, but it does work quite well. Now there's also something called Itrium Y90, which is little glass microspheres.
All right.
Is it only works well for smaller tumors. It doesn't
Right.
work for larger tumors. They don't typically like to do it in tumors larger than 2 centimeters. It was done quite a bit here in BC for a while, and I don't know why, but they're not really doing it anymore. I think they may be doing it in Kamloops, but you know, they're not doing a lot of it right now that I see. We had a patient just recently go to the States for it. Her tumors were fairly large, and they still did it. They still did Itrium Y90 for her, even though she had, like, you know, 3-4 centimeter tumors. So
Right.
I think the battle is always fought in the liver. The liver is an environment of high stem cells, and it's regenerative, and that's why cancer cells do really well there. The lung tumors are not such a concern. They can respond pretty well to, you know, targeted radiation. I would really like to, number one, see your genetics. I'm against insulin potentiation therapy. I don't think that's a good idea at all. Cancer cells love insulin, and you know, the data has really been kind of poor on that.
Yeah.
I think what we discussed today, I think there's 3 great potential combinations for you should you not have any targeted options. I think having an RNA sequencing targeted option, having your tumors run through the OmniQ RNA sequencing could come up with all kinds of potentially targeted off-label therapies. It's no guarantee, obviously, but it will definitely find
Right.
something. Definitely tell us what's best for your cancer, including which chemotherapy drugs are going to work best and which ones are not. It can take a little while. I think you could potentially go on the you know, the combination, the triplet, the tribe protocol, since you can take an EGFR inhibitor, and EGFR inhibitors are incredibly effective in 3rd and 4th line. So I'm not at least a bit surprised to hear that irinotecan and was it panitumumab you took, or cetuximab?
Panitumumab, yeah. Panitumumab, yeah.
I'm not at all surprised to hear that shrunk your tumor. Are you still on those drugs?
I am now. I just gone back I'm on cycle 5, so I basically restarted chemo
But
for the second time. I've had a couple treatments.
Did they stop those drugs for some reason, or?
No, I took a chemo break. It was a planned chemo break. I was planning to travel actually to BC over the summer. I was gone for a couple months, so the oncologist was happy to stop. I didn't have, except for the heart attack, I didn't have any side effects. Didn't even really lose my hair at this time. One treatment and the hair fell out, so it's a little different.
So,
but, you know.
So definitely, I would want to look at your genetics. Now, sorry, is it a right or left-sided tumor?
Oh, left-sided, yeah.
Left-sided, okay.
Very close to the rectum, yeah.
Okay, good. Then I would really be looking at the immune therapy combinations. You know, the nivolumab, pembrolizumab plus regorafenib, the TAS-102 plus Avastin is another combination, and then, you know, I would want to look at your genetics and see what's going on there. And potentially I would consider getting the RNA-seq test if I was you. I mean, you look fairly healthy. If you want to still fight this and keep going, it could open the door to a bunch of different treatment options. So you may have an EGFR mutation, you know, who knows what you've got.
Yeah, that would be something. I am actually, the thing that sort of threw me for a loop when I got the CT scan in August was how well I've been doing. I mean, when I was out in BC, I actually went, my brother's a bit of a health nut. He's a double lung transplant recipient. He's 10 years out, and he, you know, tries to keep himself in good shape.
Wow.
He took me and my sister and my daughter on a 40-kilometer bike ride, and I was able to keep up. You know, I was tired by the end of it, but I'm still physically okay. I'm not in pain.
Okay.
I had the heart attack, but I'm doing okay, and I kind of like to do this. I play hockey once or twice a week still.
Wonderful.
You know, I'm getting fatigued, but yeah. So I'm interested. I guess I'm just looking at cost and things like that. You're saying it runs between, you know, up to $5,000 and $30,000 to get the DNA sequencing, the tumor and the RNA, or is that
though, don't you?
Yeah, I
so
have the basic stuff. Yeah, I have some, you know, that they know that they test for. I think it's the common, the most common stuff. I mean, this is the problem with the standard care, is it's basically very limited. But I think they tested for a bunch of different things. I haven't got it. Yeah,
I'll follow up with you, John,
Yeah.
and
Sounds
answer.
like you need a follow-up conversation.
Yeah,
okay.
certainly. I mean, Alex can just have a look at what's already there and that's, I guess what he's saying is he wants to have a look at those genetics so we can see if there's any more data he can pull out, because they're often 90+% of the time there are more options that can be identified there. And then if
Sure.
not, he'll know whether you need more tumor DNA sequencing, and then also we can talk about the RNA.
Yeah, I'd definitely be looking at the RNA sequencing if I was you. And it's a cheap test. You know, it takes a little while, but it's a really cheap test.
Yep.
You know.
Mhm.
And is
I
there
just
a
wanna
problem with me being, I'm on the other side of the country. I'm in Halifax, actually.
it doesn't
now, of course,
matter.
not a problem. Okay.
We have patients all over the world.
Yeah.
Well,
It's
thanks.
the
I appreciate your
beauty of-
time.
The
It's
beauty
not
of
a problem.
the virtual
Not a
world,
problem.
for sure.
Yeah.
And I just want to say you've done so many things right.
Yeah, you have. Yes.
Like you
You've been
really,
very proactive.
you may not feel like it for how things are progressing right now, but
Yeah.
really, and even in just taking yourself away and doing the self-care and the stress reduction,
Totally.
that
Yeah.
is such a huge piece of how this disease goes for people. So good for you.
Yeah. Hang
Yeah.
in.
Thank you.
Hang
Yeah.
in there.
Thanks very much.
Okay.
Thank you. And I'm glad you found this beneficial. That's
Yes, no, I appreciate it very much. I mean, it's a small number of us here, but I think spread the word. I think this is the precision oncology is the thing of the future. The
Yeah.
POG thing, my naturopath put me onto the David Suzuki special and Nature things
Right,
about the
yeah.
POG thing and the whole idea of precision oncology, which I'd never heard of.
Yeah.
You know, your oncologist has mentioned that. So I think if more people knew about that, there might be more push to adopt some of those practices or push for better funding of it, because I think it's going to change the way cancer care will be different.
It already is. It already is.
Yeah, many countries
Yeah.
are already using this as pretty much
Mhm.
standard. Do you know it was in 2005, in preparing for all this stuff, I found another study. In 2005, a group of Canadian oncologists got together and petitioned the government to start using some basic genetic testing and PET CT scans. That's 2005. That's how long ago some doctors were already on it and wanting this, and it's still not a thing. Like, you know,
Right.
15 years later. So, and unfortunately, public healthcare oncologists really aren't permitted to recommend things they can't provide. So they can't, even if they want to tell you, hey, you can go get this test, or these folks can, they really can't tell you. So unfortunately, it's up to folks like you doing their research and, you know, just continuing to seek answers.
Well, ironically, a lot of our patients are doctors and oncologists. So
Yeah.
Yeah.
Their minds are probably more open when they become patients than when they were
Yes,
doctors
they are,
sometimes
yeah.
about.
definitely.
Yeah, and they want the best for themselves, for sure. Yeah.
Okay. Thanks for your question.
Thank you very much.
Thank you for watching CTOME TV. Subscribe below and stay informed.